So anyway, this is a 2-month-old prenatally diagnosed CPAM. Postnatal CT scan showed this lesion that you see there. And again, there was a lot of debate about whether it was an upper lobe or lower lobe lesion. And it took the reconstructions to convince me it was a lower lobe lesion. I was quite convinced initially it was upper lobe because I was convinced this right here was the major fissure. And it was just being compressed by the cystic lesion. But then when we got in, thoracoscopically, what we could see was this cystic area right here, this large cyst, separate from the upper lobe, and then this congenital cleft right here. And you'll just have to take my word for it that the rest of the CT scan, the basal segments of the lower lobe basically look normal. So is it reasonable to just resect the superior segment of this lower lobe?
Who do you want to call on?
Giovanna, what do you think?
I think that I will try to do a partial resection. I mean,
đang nói về cái trường hợp
upper.
nếu con cái thương tổn phía trên đấy thì có nên làm segmentectomy không?
Go ahead, Giovanna.
Could you hear me?
Yeah, we could. Go ahead, keep going.
Okay. My opinion is to look inside and to perform a partial resection. I mean, to perform an upper segmentectomy of the lower lobe.
Okay.
Performing exactly the same technique that Steve showed before. I don't want to do a lobectomy. I try to do a partial resection, I think.
Okay. Anyone have any other comments?
Liam,
I would say that I don't see the advantage of doing a partial resection in an infant. The downside is that you may leave disease behind, even though this is an isolated cyst. It's also more likely to have complications, although no one's done enough of them thoracoscopically to know, but certainly the risk of air leaks, et cetera, is higher. And ultimately, the pulmonary function will be the same because taking a lobectomy from an infant gives you normal pulmonary functions when you're older. So I don't really see the advantages to justify the more difficult procedure. If this patient were older, then I think a segmentectomy would make perfect sense. If there were multilobar disease, it would make sense. But it's been reasonably well documented that the risk of leaving CCAM disease behind by segmentectomy is relatively high.
Okay. Yeah, go ahead, Yama.
For segmentectomy on the left side, I think a lingulectomy or but easier than other segmentectomy. Especially, I think that is segment 6. Segmentectomy of segment 6 and segment 10 is, I think, I feel very difficult performing thoracoscopically. If I do a segmentectomy, I'm not doing thoracoscopically open technique. If I have to do segmentectomy, but if I have to do thoracoscopically, I will do left lower lobectomy in this case, as Alan said.
Okay. All right. Any
Liam? What would you do?
Prefer lobectomy. Cái này chưa bật lên này.
We can hear you. Go ahead.
Yeah, I prefer lobectomy in this case.
Okay.
So
What'd you do?
we did a segmentectomy. We completed the fissure, and you'll all get to see that video sometime in the next year. We completed the fissure, found the artery and bronchus as they came off here, had a clear demarcation plane right here, and came across it. Child had no air leak post-op. Chest tube was taken out on the second post-op day and went home on post-op day 3. Now, I do feel that this child needs to be monitored with a CT scan to do it, and I don't know I would agree with you, and the case only took about 90 minutes, and that was a fellow doing it. But to do this particular segment, I don't think is that difficult, and there is part of me that feels that, you know, if you can preserve lung, and if I knew it was disease-free, it would be hard to claim that was a wrong thing to do. But I do think, for a superior segment, I think the morbidity is extremely low for that particular segment.
But I think if you do 100 cases, okay, again, the likelihood that you're going to miss disease is significantly higher, and the likelihood that you're going to have complications of one type or another is higher.
And I can't argue that. I mean, I guess, and part of it is what I feel is, you know, based on how the anatomy presented itself and how the case went, I felt very comfortable that we were below, you know, at least grossly below the disease. And I also felt that I've done enough segments now that I feel like the risk of air leak and other issues are minimal. But I think that can't be argued. And I would like to know, you know, and I think it's a question yet to be answered. But in this particular case, it seemed a worthwhile endeavor.
Let's go. Valenzuela's on the phone. Okay. Oh, almost. Well, let's go to. He's on now. Marco, can you hear me? Dr. Valenzuela, are you there?
Now, what I wouldn't do is I wouldn't take a stapler and just wedge across this blindly. So I didn't show it, but this was an anatomic dissection.
Okay.
Complete anatomic dissection. So.
Yes. Oh, Marcelo, sorry, go ahead.
Last year we had a patient that we thought it was just a inferior lobe CPAM. When we got in, we actually saw that the compromise was in the two lobes. So we decided to perform an inferior lobectomy, and then we perform a segmentectomy of the upper lobe. And we've been following that patient. Although the segmentectomy was not perfectly anatomically performed, we felt very comfortable with it, and the patient is doing great. That's our experience. Actually, we would do that in patients that have compromise of more than one lobe.
Okay. Thanks, Marcelo.